This conference will now be recorded.
Hi, everyone. This is Debbie Bowe. I'm the Quality Improvement Coordinator for Midwest Kidney Network, and I am pleased to present the speakers for today. On the next slide, it's showing us our goals for 2021 and up to 2026. We have a 5-year contract, and what CMS is asking of the dialysis community is that 80% of patients new to dialysis will choose either transplant or a home modality within the next 5 years. So there's a lot of things that we need to do to make that happen. We had some groups that we had a few meetings, and one of the main things we found out was we have a lot of patients crashing into dialysis that have never had any pre-dialysis education. A lot of nephrologists also start patients out automatically, put in a central venous catheter and start them on in-center hemo rather than thinking about a home modality. So there's a lot of different things that we can do over the next few years. But we thought initially is just to let people know what's out there for pre-dialysis education and to also talk about the new life plan. It's a plan for allowing the patients to make their own choices according to their lifestyle and according to what they really want to do and what's valuable in their life. So this presentation will address how to use those free fabulous tools to empower every patient in their choice of modality and hopefully lead more people on the road to home dialysis. Next slide. Our speakers today are Debbie Brower-Mayer. She's a nurse from Transonic, has a lot of experience with the KDOQI vascular access guidelines, which is where Life Plan was originally formed, and I think it was 2018. And Dory Chattel is a master's in science. She works for MEI, which is Medical Education Institute, based out of Madison, Wisconsin. And they have many online tools for patients to use to choose modality. So I will let both of them do their presentation. Please, if you have questions, you can put them in the chat. Otherwise, we can address. I'd like to have a conversation at the end of this presentation. So then next would be Debbie Brower.
Okay, thank you. And hopefully the screen share is going to let me share here.
Sorry, Debbie, just 1 second.
Sure, thank you.
Here you go. You should be presented.
Thank you. And I'm just going to put this into presentation mode, and hopefully this is going to show. Let me see if I can minimize this so you all can see.
Looks fabulous.
Yep. Okay, great. So thanks everybody for joining us out of your very busy day. And I'm going to talk about the life plan and then turn it over to Dory to tell you how you can use some fantastic free tools. And free is always great. So I'm going to go ahead and, there we go. So I'll cover the life plan first and explain to that and how it can be used to help patients select home therapies. And then Dory is going to talk about the actual tools. Guys, it sounds like we are getting some background noise. I don't know if everybody can mute that's got their mics open, please. So the end-stage kidney disease life plan is new. It was put in the KDOQI vascular access guidelines, which is kind of an odd place for it to go. It really is should be part of the CKD guidelines, but those guidelines were not updated at the same time. And the life plan drives the later vascular access plans once you get your life plan created. So that's how it ended up in the vascular access guidelines. And it is a patient-physician shared documentation of the patient's choice of renal replacement therapy. So in essence, it is an informed consent. And in order for the patient to make that informed consent, they really truly do need to be offered all of the modality so they can make the proper choice. So I just want to clarify some acronyms because we all use acronyms in medicine. End-stage renal disease, or ESRD, remains the official CMS term. The National Kidney Foundation and other organizations have moved to what they're calling end-stage kidney disease. They're trying to take the word renal out because it's confusing for patients. So that's the new term that the National Kidney Foundation uses. They're basically the same thing. It's just CMS versus the NKF. Now, the life plan. the life plan is supposed to be created with a team. The main people in that team are the patient, of course, and the primary nephrologist. But it also may require, and as the patient goes into their access planning piece, whether it's PD catheter or vascular access or kidney transplant, it will require a primary surgeon to be identified. Hopefully the patient already has a primary care provider that has made the referral to the nephrologist, and then a primary interventional list, so that there's a full team that's going to deal with this patient's. The missing members of the end-stage kidney disease life plan are really what CMS mandates to be in the plan of care within the dialysis facility, which is the dialysis team. The family or support group should always be included, and the transplant team. So the life plan is in the current state. You list out those other people, but it is missing some of the key elements. And the people on this screen here, the dialysis team, the family, and the transplant team, will certainly all be involved as the life plan is updated, changed, or the patient moves through different modalities. This is a sample of the life plan. Again, the links are all there for you. These are in the just kind of the conservative care was not included, or medical management, and those are what the links are for, sorry. The life plan itself is actually a supplement from the KDOQI guidelines. So what you would do is, as the patient is progressing towards needing to have some form of renal replacement therapy, the patient and the nephrologist would talk about the various modalities. In this example, the patient has decided, and the nephrologists are going to focus on PD first. And we know that patients can live a very long time on dialysis or with a kidney transplant, and they may need to transition between multiple modalities over their lifespan. So PD in this case is what the patient wants to do first. They may want to then get listed for the transplant. And if they would get a successful transplant and there was maybe an issue that they couldn't go back to PD, hemo would be the third modality. So the idea is to look at the whole life cycle of the patient from the time their kidney disease develops until end of life, that the patient may need these different modalities. So this is a slide from the actual KDOQI guideline itself, and I wanted to explain how they see it happening as the patient in the pre-stage. They would then be able to get their access place. This is the part of the plan part, the access. So this access could be a peritoneal catheter, it could be a hemo access that matches the modality, and then again the next access. So the life plan is the top one. The access plan is actually the later plans underneath that talk about the vascular access or the dialysis access if it's PD. And that's so P for patient, L for life plan, and then the AN is the access needs. So this all layers together. And the one piece that's not shown on here is that vessel preservation runs across the entire span of this. As soon as the patient's identified with chronic kidney disease, we try to save their vessels so they don't have PICC lines or things that would damage the vessels for later vascular access. So once you've decided the patient's going to do, say, it's hemodialysis, then you would have the vascular access strategy. And basically, it's very similar to what we're all used to. You try to start with the most distal vascular access that the patient can get, whether that's a fistula or a graft, and then you move more centrally as the accesses may fail, and you're planning that if I put in a radiocephalic fistula in the wrist and that's going to fail, how am I protecting that upper arm so I can go to that upper arm? Or maybe the patient would qualify for a new endo-AV fistula that goes kind of in the almost at the elbow region. So you're trying to look at the access strategies to save those access choices as the patient's going to need them throughout their lifespan. Now, the document itself is a document of consent because it says on it that the patient is agreeing to it and that the doctor has discussed the renal replacement options and associated dialysis access. So this is really an informed consent. And the concern in the renal community with trying to implement this, and the NKF currently has an implementation committee trying to put together tools, is we really want to ensure the patient's been educated on these different modalities in a non-biased way, so the patient can actually make an informed consent and not just doing the one thing that maybe that particular dialysis center offers or that nephrologist is comfortable with. And that's where home therapies often gets left out. So Dory's going to talk about those tools that can help you with the patient education. They did note on here about language and translation. On the life plan itself, many of our patients, English is not the primary language, so we need to be sure that we're addressing the educational need in the proper language, and that if we need a translator or we need to get materials that are in different languages or availability, that we do that. And also this is contact, emergency contact, which is the closest thing to involving the family in this life plan. Which I strongly suggest that obviously families and support, or whoever the patient's significant care support is, that they all be included in helping the patient make the decision when necessary. It should be annually and updated if things change. So anytime the patient has an access intervention, that you need to update that access plan. If they, for instance, had PD and they got peritonitis and had to switch to a different modality, you're going to update the plan, and it certainly annually. And then has anything changed since the last review, life plan changed as a patient? Maybe they thought they would qualify for a kidney transplant, and for whatever reason they don't qualify. So now the patient may choose to go home instead of doing in-center hemo. So the life plan should really help the patient. How's it going to help with selecting home therapies? It really should help the patients be able to select home therapies, because it should ensure the patient's actually offered home therapies. I did acute dialysis for many years, and often as the dialysis nurse, I was the first one that actually told the patient that there was something other than that catheter in their chest to be hooked up to a machine, because that's what they got in that acute arena, and they didn't understand that they could do this at home, that they could do peritoneal dialysis. So nurses and patient care technicians are extremely important as we encounter patients to also provide that education. And again, I said it's a informed consent. It really means the patient needs to be told about all those modalities. They need to not just be kind of told, well, you're going to do in-center hemo and, you put the catheter in and off you go. They really should be informed on all of these modalities and understand them before that life plan is actually created and signed. The American Medical Association has a statement about informed consent. It has, this is the legal definition. It's really about medical ethics. We really do want to make sure that the patient understands what we're telling them, that they've asked their questions, that it's been in a non-biased way, and that it's really a shared decision-making that the patient has come to. So the tools that, again, Dory will show you will help us do that. And here, just highlighted some important things like the patient's ability to understand the relevant medical information. We really need to explain it in a way the patient understands it, that the information is certainly told to them in an accurate way, that the patient, again, is getting non-biased information. And then the risks and burdens and the expected benefits of all the options are really explained well, and not used as a way to talk a patient out of it, but as a way to actually provide the patient all of the information. I used to work with a nephrologist who hated PD, and if a patient asked about PD, he would go into a spiel on peritonitis, and patients would immediately become very nervous and often would back off of that suggestion of a potential option, because that particular nephrologist didn't like PD and he thought everybody would get peritonitis. So we need to be careful that we're not including our bias when we're providing this informed consent to the patients. And even though we're not the physician signing it, we're part of the care team providing the education often. We're the nurse or the tech that's there when the patient's asking questions and the doctor walks away. We tend to be the one to provide all of the additional information. So it really requires communication and education. Those of you that are involved with the CKD clinic, this is the perfect time to start the discussions and to start those life plans. certainly when they crash land in the acute arena or in the hospital, it's not too late to start that life plan and talk about all those treatments. We're seeing more acute peritoneal dialysis being done in hospitals. So some patients that crash land can start right on PD and never have to be put on acute hemo as a way to, if they want to do PD, keep them from having to have a hemocatheter. Certainly outpatient dialysis, we know that, there's a lot of things that happen to patients where they may need to change modality, they may need to change access. Those patients that have a CVC only, they've got the catheter in, and they can easily get a PD catheter put in and switch to that. And then there's the newer transitional care units, which are basically allowing patients that are new to dialysis to come in and be exposed to all the different types of dialysis, with a lot more staff education being provided to them than the typical outpatient clinic. So the patient gets exposed to the different things and they can truly make an informed consent. As many of you know, when patients first start dialysis, they're often so overwhelmed and they could be uremic and they have trouble understanding what we're even telling them. So the transitional care units allow that time for the patient to make decisions. That is being highly sponsored by a lot of the home therapies such as Next Stage, and I did include the links on the bottom to some of their information about transitional care units. Fresenius is starting to widely accept those now. So we, again, need to help be advocates. And I always like to point out when I'm talking to any of the non-physician groups that nurses are always rated as one of the most trusted professionals, higher rating than physicians. Patients ask us questions because they want to know the right answer and they trust us. So we have to be very well informed about all the modalities. We have to be careful we don't bring our biases to it, and we teach the patients in a way that they can understand it so they can really make those informed decisions. And again, the tools will really help you do that. So I like this quote from Walt Disney: the way to get started is to quit talking and begin doing. And I think we're finally getting to that point in dialysis with home therapies. Instead of just being this kind of idea we all talk about as the better way to do things, the way that we would probably all choose to want to be dialyzed, we're now starting to bring that to our patients. And I'm very glad that we're now doing. So Dory is going to share the fabulous, fabulous free tools. So I'm going to stop sharing here.
All right, and hopefully I can start. Let's see.
Here you go, Dory.
Oh, excellent. That looks like it worked. Let's open this. And let me
Thank you.
get it there. Yay! I love it when a plan comes together. Thank you so much, Debbie and Debbie, for Debbie Bowe for inviting Debbie and me to do this, and Debbie Brower for giving us such a great background on the Kidney Life Plan. And I am really excited to get a chance to talk with you about free fabulous tools. And of course, maybe a couple other things. So I run Medical Education Institute. Hopefully y'all are familiar with us at this point. If not, we do lots and lots of different things, but quite a lot of them touch home dialysis in some way. So we do the Home Dialysis Central website, and we do the decision aid and a book and all kinds of things, some of which I will be telling you more about, so I won't belabor those. But before I get to the tools, I do want to tell you where the patients are coming from in all of this, because we do need to get them to a point of informed consent, and we do need them to understand the options, but we can't start there. And here's why. Where the patients are coming from is kidney failure is a tsunami in their lives. This is a personal tidal wave. It can wash away everything that they are used to in their lives, everything they value, everything they care about. And for some, this may well be the worst thing that has ever happened to them in their lives. They are shell-shocked. And I kind of like to think of them as sort of standing in the muck as the wave recedes, blinking and just kind of staring off into the distance because they're in shock and they don't even know what's going on. And this is important to keep in mind because for us, this is sort of every day, okay, got to get this information into this person's head. But for those patients, we can't get the information in until they're ready to receive it. And that's a critical point. Patients don't want dialysis. How do I know this? Because in the 32 years I've spent working in the renal community, I have dedicated my career to listening to patients every single day. And I've been doing that since 1995. And at this point, it's somewhere between 15 and 20,000 different patients that I have interacted with at every stage of kidney disease, patients and care partners, and every modality option. And they all have a couple of things in common. One of them is they don't want their lives to change. They don't want this to be happening, and they do not want dialysis. And I would argue that that's probably a major reason why 50 or 60% of our population crashes into dialysis emergently, even though probably half of them knew their kidneys were failing. They had diabetes, they had hypertension, they were told, but they weren't given any hope. So it is 100% normal for people to have sometimes multiple different conflicting emotions, none of which are much fun. It's very common for patients to be angry, angry at their doctor if they missed a diagnosis, especially if they've been seeing that doctor for a long time, angry with themselves for not following their treatment plan, not taking their blood pressure meds, you know, I wish I had done that, and angry at God if they are people of faith, and that's a very difficult place to be. They may be depressed. At any given moment, about 1 in 5 people with end-stage kidney failure is depressed, and without treatment, they will stay depressed. But the predominant emotion is fear. They are terrified, and being terrified is a real problem for us, which I will tell you in one more slide. But what they're mostly afraid of is that the life that they're going to have on dialysis isn't going to be worth living. They're not going to be able to do the things they want to do. They often have family members or friends. They've known somebody on dialysis who didn't do well, and they saw how they didn't do well. So we're not necessarily educating in a vacuum here. These are, you know, largely adults who have life experience, and their life experience around dialysis may not be good. Every single aspect of lifestyle is threatened when the kidneys fail. What people can eat, how much and what they can drink, how many meds they need to take, whether they can travel, keep a job, their sexuality, their fertility, when they get up in the morning, how much control they feel over their lives, everything is threatened. So they are right to be fearful, because if they don't make a choice that fits their lives, they could lose everything. And I am sure that we are all familiar with patients whose marriages broke up, who lost their homes, who might have even ended up homeless, lost their jobs, you know, lost their standard of living. They give up a lot to go on dialysis, and that doesn't have to happen if they make the right choice. But they don't know that because we don't talk about treatment options generally in terms of lifestyle. We talk about them in clinical terms. We can remove water and wastes from your blood. We can do it this way, or we could do it that way. Here's the thing, they don't care. What they want is their lives as much the way they used to be as they can get them. That's what matters to the patients. And that's where they're coming from. And this is why it's important. That fear that they have, that frozen terror of, oh my God, I'm going to lose everything. Humans cannot learn when we are afraid. When adrenaline, cortisone are pumping, we can freeze or we can run, but we cannot learn. So until we get past the fear, we are trying to educate people at the worst possible time when they are least capable of learning. And what that leads to, and what we've seen, and this is how our community is set up, is 90+% of patients using standard in-center hemo. If we want that to change, we have to change drastically how we approach people about treatment options. And it can't just be a clinical, we could do this or that, pick one, because they're not going to pick one. They're going to pick in-center and nothing will change. Hope matters a lot. And there are several more little studies on hope. There aren't a lot of them, but I really like this one because it's just kind of very clean. So what they found is that patients who were more hopeful were not as anxious. So there goes the fear. Hope reduces fear. They were less depressed. They didn't feel as burdened. And if anyone is a social worker, they had better mental functioning. And better mental functioning in end-stage kidney disease predicts lower hospitalization and less death. And that means that hope is literally a life and death prospect. And what the author said is hopefulness could serve to lessen the emotional impact of end-stage renal failure and treatment by empowering the individual to reframe threats as challenges. So we can help them with that fear, help them get past it by giving them hope. And we've got to do that first, because if we try to wait and do it later, they won't have heard anything we said because they can't. So there are treatments that match people's lifestyle and their values. And what we need to do is help people to find their way to those. So that's what the free fabulous tools do. We have all kinds of tools, y'all. So we have a free CKD slide toolkit that has 6 different decks that go everything from kidneys and kidney disease to treatment modalities, transplant, how to pay for dialysis, all kinds of things. All of these decks are MIPA appropriate. They all come with learning objectives, speaker's notes, handouts. They are not copyrighted. You can change them if you want, and they're free. They're free download. The URL for the download is right on here, and you will get a copy of these slides. And you can use these one-on-one. You can use them for groups. You can put them on a tablet. And they are purposely mostly pictures, as you can see, with the only words that are on these slides are the ones that are essential for the handouts to make any sense. So these are not the typical, 100 words on a slide sort of slides. These were designed especially for people who are scared right now and who need some hope and some reassurance. We have Home Dialysis Central. Hopefully y'all are aware of that, but Home Dialysis Central has reams and reams and reams of free things. Life at home articles, there are dozens of them. They are all referenced, they are all maybe 3 or 4 pages long, and they are all written at a 5th or 6th grade reading level because we know people are afraid. The blogs are more for you, and if you would like to write blogs, I need one for every single Thursday of the year, and we love guest bloggers, so please consider doing that. On Home Dialysis Central, we do have nice, detailed, easy to read information about all of the types of dialysis, of home dialysis. And these are, you can drill down for each of these. You click that bar and you can get more information. And we even have a new section on the site for solo home hemodialysis, because one of the big barriers for home hemo is patients who don't have partners. And if they are capable adults who don't have serious anxiety problems and don't have manual dexterity problems and can see pretty well, they may be candidates to do solo home hemo. At this point, that's only approved with a next stage machine during waking hours. But I can tell you in our Facebook group for Home Dialysis Central, which has more than 6,000 members at this point, we have lots of folks who are safely doing solo home hemo. And it is safer to do solo home hemo than it is to do standard in-center hemo in terms of your heart and your brain and your life. We have an ultrafiltration rate calculator, which can be a great way to help people who are not happy in center realize that if they could be removing water more gently, they might feel a lot better. This is also a great tool for folks who are doing home hemo because they can use it before each treatment and make sure they're not trying to pull a volume of water that is going to be harmful for them. So this is important for both audiences, and it's free. This is maybe our most valuable tool for where you all are right now. My Life, My Dialysis Choice is a treatment matcher or a decision aid. And this follows all of the criteria of the International Patient Decision Aid Society, and it's written at a 5th grade reading level. It's in English and in Spanish, and it's free. And ideally, try it yourself. See how this works for you. Choose 3 values, because this works best when folks use it and realize that the option they always kind of had in their head of this is what they would do isn't necessarily the best fit for their lives and their values. This can be used on a tablet, and Fresenius has actually adopted it corporate-wide and is trialing it in the transitional care units where it is performing very, very well, and it is helping people. The main goal of this tool is to give people hope and to help them match a treatment option with what matters to them. So this isn't just teaching them about the options. In fact, it doesn't teach them that much about them. That's the next step. But it teaches them which ones might fit their lives and gives them hope that they can have a life that is worth living. So what folks do is choose a value. There are 3 different categories, only 2 of them show on this slide. But in a clinical setting, typically have people choose their top 3 values. They can always go back, do it again, fill out more values later if they want to. Focuses on what matters to you. And for each value they choose, they're going to see a page just like this one that's going to cover peritoneal dialysis, standard hemo in-center and at home, daily hemo, and nocturnal hemo in-center and at home with pros and cons, but the pros and cons are specific to the value. They're not the generic pros and cons of, to do PD, you have to have a tube in your belly and you got to wash your hands and you have to have a lot of room for storage. And for hemo, there are needles, and those are not the pros and cons that we're covering. And to the extent possible, all of these are based on evidence. I am actually reworking the book that this tool was based on and the tool. And when this comes out again next year, it's also going to include transplant and conservative care. And it's going to be a kidney life plan. So we're not quite there yet, but that's what we're working toward. This is the summary page that the tool comes out with. So what this gives you on one page is what matters the most to your patients and which options are they the most intrigued by. And what that means is that the conversation about treatment options can start in a completely different place. Instead of trying to quickly educate people about what all the options are when they don't want any of them, this sort of routes around all of that terror, and the conversation can start with, okay, it looks like you might be interested in PD and daily hemo. Tell me a little bit more about why those intrigued you, and let's have you talk to the home training nurse. This tool is working. Fresenius would not have adopted it if it wasn't. So this is probably your most valuable freebie that I will offer you today. We have Path D tools. This is partner agreement on tasks for home dialysis. There's one for PD and there's one for home HD. And these are almost like a magazine survey, like Cosmo. You fill one out, your partner fills one out, you see if you're on the right page, same page. That's exactly what these are intended to do. And the reason that we develop these is that there are a lot of people who won't even try a home therapy because they are afraid that they will overburden their partners. So this is a list of 20 tasks that have to be done with each treatment, and people can see who's going to do which ones. Or if they want to do solo, see if they think they can do each one. And you can use this while they're contemplating. If they express any concern about partner burden, you can use it at the start of training, you can use it at the end of training, and you can use it again if there is some sort of a change in status that requires a change in partner and care, patient and care partner role. And you also, when you see people do this and fill it out, and then they're not on the same page, it's going to give you some pretty good insight into how well a patient and a potential care partner interact and whether they are in fact good candidates to do a home treatment. They need to be respectful and they need to cooperate. And if they can't do that in front of you, they certainly can't do it on their own. So some takeaways. Patients are terrified and they cannot learn as long as they stay that way. We have got to give them hope. The treatment that they choose affects every part of their life. So we need to make this choice a lifestyle choice, not just a clinical clean your blood choice. It's the most valuable thing that we can help people do is figure out which option will fit their lives the best. This concept of fit is really important. And we actually are doing a study right now looking at developing a measure of goodness of fit of dialysis to people's lives. And you can help your patients do this, and it's incredibly rewarding and gratifying to do that. And now you've got lots of tools to help. So thank you. And we've got lots of time for questions, so I hope you all have some questions.
Thanks, Dory and Debbie. Any questions on any part of the tools or life plan? I'm going to start calling on people. And what I hate to put people on the spot, but I'm going to. Val Riley, I see you're on and you're from FMC, and I'm really curious about the transitional care units and how you use this information. Is that something that you could address?
Not currently, because I'm really not associated with home therapies. We are skilling up in my role
Okay.
on home modalities. I do have a visit planned to our TCU in the very near future, so I'm going to ask to see this in the clinic.
Okay.
But
Excellent.
But here's is there a link that you could put in the chat for us to link to these tools so that when I'm out in the clinics, I can show them where they're at in case they don't have them?
Let's see.
Yes, we will have a link.
Okay, let's see. So when the new tool will be available? Excellent question. I wish I could give you an exact date. I cannot because it's new and developmental, and hopefully we will have it out by the end of Q1 next year. If I had to guess, it might be Q2, but we're going to aim really hard for Q1 and see if we can make it. We're really excited about it. It is going to be very, very cool. Okay, so there's My Life, My Dialysis choice. Oops, Home Dialysis Central. All right, how about, does anybody have any like tricky patients, challenges that would be useful? I'm not saying I can answer all the questions, but your colleagues in this call have a lot of wisdom to share also.
One thing I have a question for the group is, do any of you work in CKD clinics that you can get to those patients before they crash into dialysis? Is there anyone on the call that has that capability within their system or are just starting to do that? I know some of the hospital groups, Avira or Aspirus, do you have any? Jesus Almeida, do you have anything with Aspirus that adjust the CKD clinics before they crash?
Deb, can you hear me?
Yes,
Yeah, it's a random case really, but majority of our patients in Aspirus ending up in the outpatient dialysis come from the outpatient nephrology clinic. In regards to life plan and patient education, there might be some substance in the life plan information that has been presented a while ago that has been discussed in the clinic, but there's no consistency related to it. I think one takeaway that I have on this presentation is to make sure that we use patient-friendly language and dialogue when we're communicating with the patients, giving emphasis to the life plan.
Right. And do you see any way of merging that with your actual initial 30-day, 90-day annual care plans?
Right. I just submitted a question on if there is a recommended way for us to document this. It is on the very early stage that we have a discussion on the life plan with the other dialysis clinics in the Aspirus system. But that is one route that we are focusing on, is to incorporate it in the plan of care of the patient, being the physician and the interdisciplinary team is involved in this discussion together with the patient and the family support.
Right. There is another question. How do you usually go about encouraging a long-time in-center hemo patient to consider home or transplant? We find that once someone is comfortable in-center, it becomes difficult to present other options to them.
Oh, me. I see this a lot. So here's the thing. We do not want to approach people by saying, have you thought about home? Have you thought about PD? Have you thought about home hemo? Remember, they don't want any dialysis. They don't want the one they're on, and they certainly don't want one that looks like it's going to be more work for them. A fair number of them have the mistaken perception that clinics make more money on home dialysis, and so they're trying to push people out the door to help themselves. And oh gosh, there's a lot of misconceptions out there. The thing
Yeah.
to do is to use the decision aid, if possible. Find out what matters to them. Listen to their complaints. Complaints are things that can often be addressed with a home therapy. You know, my life is not working. Oh my God, I lost my job and I can't make my car payment. You know, my wife really wants to have a baby. You know, whatever. There's always something. You know, I feel like I can't eat anything. I may as well throw away the food and eat the box, is one quote we actually got from a patient. So these sorts of gripes come up all the time. It's summer. I'm so thirsty. You know, it's so hard to have to watch every drop of fluid. Every single one of these complaints can be improved, you know, can be addressed by switching to an option where you can keep a job, you can have a baby, you don't have to be so limited in your fluids. So find out what it is they're griping about, because everybody's got a gripe. We all do. I'm not on dialysis. I have plenty of gripes, right? Don't we all have gripes? They do too. And theirs tell us what matters to them. I strongly recommend using the tool, but even if you don't, get to know your patients, or your techs get to know your patients, you know, and they could say, you know, your life could be way better than it is in these areas. And, you know, do you want to see how? The tool shows them how. Once they're receptive, then you can have them talk to the home nurse.
There's a note too, the University of Michigan has a CKD program that Valid worked at before going back to FMC. Is that Michigan or Minnesota?
Minnesota.
Minnesota, okay.
Yeah, they have a pretty defined CKD program.
Okay, perfect. I'll reach out to them. Dory, do you remember working with them at all?
I sure don't, but I would love to know what they're up to.
Yeah, that'd be great. Nice to know if there's set programs out there. Another question, Greenfield Henry Ford has a process. Lori,
Yeah.
Amber, can you expand?
Can you hear me?
Yes,
Okay, yes, I have Victoria Lorenzi Jump here, who's in charge of our CKD education program. And so
Okay.
we have some traditional classes. Come on, Victoria, and say a few things.
So we have a program called SWAT, which is Swiftly Treating Treatment Choices. And that's used with patients that are in center or in the hospitals that are newly diagnosed to end stage renal. So they've lost their kidneys. So they're dealing with all of the confusion, which we all know, the renal issues that come up. And barriers is one of the big ones. So when we do the bedside education, we address the barriers first. And then we also have videos that we put up on their TV so they can watch those while they're admitted to slowly digest what some of the treatment choices are and get them thinking about. So when they start talking about some of their barriers, like we earlier talked about, we reverse it to taking those negatives and making them a positive and find out, oh, so that's really the problem. It's not so much that you want to go home, but it's how much burden am I going to put on everybody else in the home? So yeah, I would like to do that, but I can't because of this. So we start those conversations early. By the time they get down into the units, then they're easy to talk further with a PD nurse at that point. Or some of them have even said, well, let's talk about the treatment choices. And then we start those conversations sometimes in the hospital. And we have had few patients that have made those choices. And I say few because we'd rather wait for them now that they've got the CVC in and they're going to go down into the units for a period of time to adjust. We would rather them do that at first before we say, hey, guess what? You said you were interested in PD when you were in the hospital. How do you feel about that now? Let's start that conversation again. So it's just another way for us to reach out to patients early.
Have you considered an urgent start PD program so that the folks interested in PD could not start out with a CVC and start out with a PD catheter instead?
We did talk about that, and we have had a few patients do urgent start, and it's kind of funny because Victoria and I were talking about that a little bit earlier, that didn't take off as well. So we are looking at, talking to some of our physician leaders, our chief medical officer, people like that about what about that? Let's try that again, because we did have a few urgent starts that worked well.
Yeah, keeping folks in their lives has a lot to recommend it, and PD is such a great first treatment for, the 2/3 of folks who physically can do it.
Yep. And then we do have a CKD program where we have classes, and we do sometimes Victoria gets interpreters to help with that. It has family members be able to come attend to help with that support as well.
Yeah, and then we also do private classes for those large families or people that just feel uncomfortable with their level of education to be in a group setting. So we really cater.
That's a really nice approach.
Thank you.
So for Greenfield Health, this is Debbie. I would just ask if you guys would look at that value tool that Dory has and see if maybe that would fit in that she showed, because
yeah, we actually took notes and thought that sounded really great.
Awesome.
Right.
We were already
It's
saying,
a wonderful tool.
we need to do this. And
Yeah.
then the other thing about when we talk to people in the units who are on in-center hemo, we're trying to address them rather than saying, I don't know who said it, but they were so correct, rather than saying, have you thought about, is having them maybe use that tool again to relook at stuff. So
that a trial doing exactly that is why Fresenius started to use our decision aid in the first place. The first use that they made of it was to get in-center patients home, and it was more successful than anything else that was tried in the US, and so it kind of took off from there.
Yeah, no, it sounds awesome. Yeah, we were already on that. Write that down. So thank you, ladies.
Dory, can you put in the chat the link to it? You have to pay for it, but there's an absolutely amazing book, Help I Need
the help book?
Dialysis. Yes.
The book is not free, so I didn't include it, but that's what the basis of the tool. And the book is only $6 now. It's pretty cheap. We still have some left from the 2012 edition, which is why we're updating it.
It's the book for those guys. If you check out the link to it, the book is written for patients, and you know, I've been a dialysis nurse since 1983 and done all forms of dialysis. And several years back, my father-in-law got diagnosed with needing end-stage kidney disease and needing dialysis, and I did not want to bias them in any way, shape, or form. So I gave them the book, and they took a highlighter and stickies, and they went through the book front to back more than once, and then we sat down and did all the questions. He did PD because of reading the book and choosing it himself, and did extremely well on PD. Unfortunately, he got an infection and ended up having to go in center hemo, and got COVID and passed away from that. So we lost him, but his life was extended and had very good quality of life because of PD. And you know, I just, so you know, we think we're experts on talking to patients, but we have to be careful that our biases don't come across. I have to say I was thrilled they picked PD, but I wanted it to be his choice and my mother-in-law's choice so that they understood the work that was involved and would really commit to it. So I can't endorse the book more than tell you it works. I've used it in my own family.
I used it with my neighbor right across the street when her dad started on dialysis, because she came over to my house, brought me a big flat of peaches because they had gone peach picking, and I said, how are you doing? How are things going? She's like, well, my dad's kidneys are failing. And I'm like, do you know what I do for a living? And she's like, no, we've never talked about it. I'm like, well, I do education for people with kidney disease. And we gave her a book, and her dad picked PD too, and he did great on it, except that they told him to, he was 83, told him to go about his usual activities and didn't ask him what those were. And he liked to golf. So he went golfing with a full belly and leaked into his scrotum and had to stop doing PD and switch to in-center HD, on which he was not nearly as happy, but he actually lived for about 5 years and chose to stop during COVID because, you know, he couldn't really do anything he wanted to.
One thing I want to say for the network is we do have 4 different groups for trying to improve home dialysis. One is the CKD 4 and 5 education. Another is educating physicians about home modalities. A lot of practicing physicians aren't real pro-home, and a lot of the fellows that come out of the programs have probably not had much, if any, experience in a home dialysis unit for them to be trained on it. Also, there's talk of skilled nursing facilities having dialysis in there, considering that the patient's home, HHD or PD. And so there's different groups. If anyone is interested, please, there's a Survey Monkey we'll be sending out with the slides later. If you are interested in participating in any of these groups, if you have a plan that you're working on. And at the end of this one, I'm asking for people, if anyone's interested in trialing these tools and seeing how it works, and just keeping track of numbers, percentages of how well they work for your unit and how many people you switch over to home dialysis. So there's a lot of different opportunities. You know, it kind of goes in 6 different directions. So we're trying to hit on as many as we could, but we felt that this was the most important, because just to get the basic information out, how to approach patients, I think is probably the most important piece. And then we can work on the other parts yet after that. But that's kind of what we're working on in home dialysis. Are there any other questions, ideas, thoughts? We're getting near the end of the hour. If you do have questions, please let us know. I will be sending out the recording, the slides, which will give you the links. And then there is a Survey Monkey. If you could flip the slide, Kristen. There is a Survey Monkey that we're going to be sending out. And we're going to be looking for people that are interested in participating in a project using these tools, whether it be in a transitional care unit, whether it be in a CKD clinic, whether it be in an in-center dialysis unit. We're interested in people that are wanting to participate in using some of these and seeing how that can affect your home dialysis rates. And then the next slide shows the actual SurveyMonkey link. It will be sent out to you in an email. And also looking for future topics you would like to see on how to expand life plan education. This is kind of the first foray that we've had giving information out, how you feel it should be spread to other units. I think, you know, people are going to have to look at how to merge this with their own care planning that they do in the unit, and kind of combine the two and have the pieces that are in the life plan as a part of their actual care conference that you do every year and at initiation of dialysis. So anyone interested, please, on the SurveyMonkey, there's a place to list if you're interested, and then just put your contact information. So then we will be contacting you as soon as we get your name and number, and then see if you're interested in working with any of the groups. Any other questions? Or at the end, we've got my email. Candy Coles is my boss. She works on transplant, but she's also part of Life Plan. And then Kristen Ward is the one that does all the data. So anyone, if you have any questions, please feel free to contact any of us. Also, please feel free to contact the presenters. If you have specific questions for them, you can send them to us and we can send them on to them. Or do you want us to list out your email addresses, Debbie and Dory?
Sure, you can share mine.
Okay.
Here's mine in the chat.
Okay, thank you. So then if you have any specific questions for them, feel free to contact them directly. So thank you everyone for taking the time out of your day to listen to this. It was recorded, so we will be sending it out. So please pass it on to your managers, to your social workers, to CKD clinic staff, to inpatient dialysis staff. Is another place where that education can start too. So I think a lot of this information needs to be spread, and you guys are the ones that have the best way to get a hold of those people. So thank you for attending and spread the word, and we will continue to work on this project. And if you have any ideas or questions, please let us know.
Thank
Thanks,
you.
Debbie.
Thanks, everybody.
Thanks.
Take care. Have a great day.